Hey, look, can I just start by kind of really saying what an amazing amount of work. I've spent a lot of the time this morning going around all of your storyboards, and what an amazing amount of work you've done. I just want to acknowledge that, really. I think there's some great ideas there, and particularly change ideas that you are in the process of or are going to be testing. I guess implicit in this methodology is change ideas, and what change ideas are about change. So the team at Health Quality Safety Commissioner just asked me to talk a little bit about change and then about perhaps transformational change a little bit, and to give some examples of that. I mean, we live in an environment where actually the people of New Zealand, if you've read the inquiry report, certainly the inquiry panel, and from the signals from government, I would say government as well are expecting of us transformational change. Now, how that's going to happen remains to be seen, but I mean, that's the reality that we live in. And I mean, for me it was, as I'm sure it was for you, distressing to read words like the system is broken, although at times I'm sure we all feel that as well. So I was just going to talk a little bit then about change first of all. I mean, the rest of the health sector has really embraced some pretty profound changes in the last 20 years. The thing I really think of was laparoscopic surgery. When I was a house surgeon, if you had a cholecystectomy, you're in hospital for a week and you were cut from one end of your tummy to the other. My wife had one about 5 years ago, and she came out after a night stay with 2 little kind of stitch holes for the lap surgery. So, I mean, that's a transformational change, isn't it? And it's had a huge impact on delivery of surgical services. There are many other examples. I mean, I think we've kind of really struggled in this space, though, and I've talked about that, I think, a little bit last time, but I think there are things that people do struggle to access currently. So I certainly believe that we need to be supported, enabled to transform how we deliver services. I totally agree with Kevin. I mean, I think that it's really important to come into this work knowing that no one lies in bed at night dreaming up ways to do things badly. We all go into work to try and do a good job. But as I think I showed last time, I think we are at risk of being stuck in this place. And partly I think that's where this methodology comes in, because I think I said last time that my experience is that this methodology really liberates people to embrace change and for it to be a fun thing that they feel in control of, rather than our historic experience, which is change as something that's done to us. I think in surgery it is kind of easier because it's what the surgeon and the theatre team do that has the biggest impact on outcome, whereas in mental health it's not the same. So actually our job is not so much to focus on what we do as what the people we work with do, yeah, because it's what they do that mostly has an impact on outcome. So these are some slides which are talking about the fact that in quality, if you think of hitting a kind of a dartboard, if you practice enough, you'll get to the bullseye. But actually, we're not kind of trying to throw a dart to a bullseye. And this guy talks about the fact that actually it's trying to throw a bird at a bullseye. And if the bird decides to fly off, we can't do anything about it. So how can we get the bird to go to the bullseye is our challenge, isn't it? And I mean, so just again, a reflection on the same thing. I mean, in most of the work we do outside of places like mental health ICUs, it's what the people do that actually makes a difference. And that's fundamentally what we've got to work with. And we all face this, don't we? I mean, if I talk to people about what they do and how they would want to do it different, everyone is full of ideas about what they would want to do differently. And on the other hand, when it comes to organisational stuff, I think we all talk about change fatigue, and so that's a real challenge in this space. And so partly I think it really comes down to this, that we've all really experienced change as being something that's actually enforced on us and by people who are not actually practising day to day and doing what we're doing. And so it becomes easy to just get into the space of resisting it, or of kind of going through the motions of saying, yeah, we'll do it, when really your heart's not in it. So, I mean, it's well recognised, and I think the lovely thing about this methodology is it addresses a lot of this stuff, because it does allow for tests of change that are small. It puts clinicians in control of change process. It inherently, when you're kind of getting data that shows your changes in real life, it actually becomes a focus for celebrating change and so on. So look, in terms of change then, there is this, there are a number of ways people look at change, and the most simple is this notion of first order change, which is, put simply the way I see it, that's like refining business as usual. And then the second order change, which is fundamentally changing from business as usual. And I'll give you a couple of examples of that from some work we're doing in my setting, which is a primary mental health one, as most of you know. But I mean, we've historically operated a co-located, so our services are delivered in largely general practice settings, but referral-based service. And despite a lot of effort, have on average only ever engaged 50% of the people referred to us. So we saw that a couple of years ago as our biggest quality problem. And we did some work which was about first order change. It was about testing things like, well, okay, we've got a peer workforce, let's test getting them to do some outreach to see if that impacts on engagement, and it did a bit. Let's try get co-designing with people who use the services, the information we send out to make it more inviting, and it did change things a bit. So we did see some incremental change. And in this problem we were facing, though, we also decided to test, and we could only do it in 2 sites because it was a resource implication thing, but to test a totally different model. So that was having a peer health coach and a mental health clinician, what we call a wellness advisor, as part of the GP team. So a no referral, warm handoff, see people on the day model. And almost overnight, our engagement rates went from under 50% in those 2 clinics to over 90%. And until the first 2 months, we saw more people from that clinic than we had in the whole previous year. So it's kind of an example of how sometimes you can see big improvements, actually, in my example it wasn't, but big improvements with first order, but sometimes you do need to look at second order. When I look around your storyboards, I see a real mix of first and second order change ideas, and some of the things that really stuck in my mind, brought joy to my heart, were things like testing peer roles in an inpatient unit, for example, engaging with family in the process, and things like that that fundamentally are a shift from business as usual. And another way of looking at it, which is kind of similar but different, is that there's developmental change. So that's the improving business as usual. There's transformational change, which is changing business as usual. And in the middle, talking about this kind of middle state, which is about not necessarily changing your whole model of doing things, but changing some aspects of it. So what's the big deal here anyway? Look, I mean, I often find myself coming back to this in terms of why some degree of transformational change is needed. And this is simply about the economics of healthcare, that basically we're spending more and more and more on healthcare, and on most measures of population health, things are getting worse. So actually, we're not doing that sharper job, and we do need to transform. And you could use similar kind of metrics around the way we approach mental health care and make the same argument. So there's also this notion of disruptive innovation, isn't there? And I mean, some examples of that are things like Uber, which has totally transformed what was the taxi industry, you know, or Netflix. So, you know, why is Sky Television, why is Sky going out of business? It's literally because we can all access Netflix when we want, whatever we want, and so on. Airbnb, I mean, Airbnb are currently the biggest hotel chain in the world, and they don't own any beds. So there are all these examples. So just a couple of examples of stuff that I think at least sits in the transformational space in mental health. There are many of them. I'm just using these two as some things that I've had some involvement in. So I don't know how many of you are familiar with some of the evolving applications of AI in mental health, but this is one of them. It's actually not a New Zealand developed one, but there is some stuff happening in this space locally as well. So it's basically a chatbot therapist, okay? And you might laugh at that, you know, and people's first response is, you know, who would want to actually get therapy from a robot, yeah? Funnily enough, because funnily enough, actually, it's indirectly related, but in one of my roles, we tested phone-delivered therapies to a rural PHO, and we were kind of thinking, look, we don't have the resource to do this properly, so we'll just do it by phone, but if it works, we'll get it set up for Skype and so on. One of the really surprising things about the the qualitative part of the evaluation was that actually for a lot of people, it was being by phone that made it feel acceptable because it was anonymous. This is even more anonymous, and I think the reality is that it's going to meet a huge need that at the moment is unmet. People who won't see a person because of stigma. So, look, it's really hard to read it, but you can see an example of the kind of text exchange on the side there, which is, Mark is proactively being reached out to. What are you up to? And he says, I'm studying for an exam, freaking out. Totally understandable, so normalising. I think it shows how committed you are to doing well, so some positive reinforcement. I could help you dial it down a little. Would that be of interest? So asking a question around, would something be helpful? And then, the beginning of then inquiring around what are some of the negative thoughts you're having. And if you think more broadly, this is the kind of menu of things that can be done using that kind of model, okay, which is evolving. So, I don't feel at all threatened by this personally, because the reality is that there is always going to be more work in this space than there are people to do it. And I think it's about having choices for people, but I think that these are the kind of things that are potentially going to, at the very least, be about transforming the way that we provide mental health care. Yeah, look, again, that's about some of the broader applications. I see it as particularly operating in the space for people with long-term conditions as well, around self-management. If you look at the advantages, I've covered a lot of it, but 24/7 availability. Therapists are expensive. This thing isn't, and so on and so on. And you might say, well, will AI ever replace docs? And this is doctor stuff. And it's purely looking at diagnosis, okay? This in 2016 was the state of the Who Does Best. So it was basically tied for, where's the pointer? Tied for these areas. The AI diagnostic tools beat the docs in 4 spaces, and the docs came out on top on general diagnosis. So I guess what that's saying is people are still better at doing the wide scan stuff, but that the AI tools that are developing are actually doing well in some spaces. And again, I don't think this is anything to be scared of. I think what this does is actually free us up to actually focus on the person-to-person aspects, and as well, rather than having to worry about all the kind of other things that are in the space. So, look, just have a scan of this in terms of a potential future scenario in a GP office. You might be surprised to know that in terms of speech recognition software, there is research showing that a person's use of pronouns analysed through AI is more reliable in detecting depression than psychiatrists. So the second thing that potentially is potential to transform what we do. This is one of many examples of initiatives which have come on the heels of the Genome Project, which basically spent billions unravelling the human genome, and now you can get yourself genotyped for $500. In fact, if you want to get a whole lot of analysis back, it costs that. If you want to just do it and get the raw data back, I think it costs about $150. So what crew? This is a local, as an Australian, as opposed to American, but there are others. What these firms are doing now is providing a service whereby you get all of your genetic polymorphisms typed, and then it gets connected into a personalised prescription around your lifestyle stuff. So, for example, I was a guinea pig for one of my mates who's a GP who was training for this, and it kind of told me stuff I'll intuitively known. I'm best doing a mix of aerobic and resistance exercise than just aerobic. So what's best for me is to do some aerobics and weights. And actually, my genetic profile says that that's actually what's right for me. But so you get advice about things like lifestyle, supplements, diet, and also medically about the kinds of medications that are likely to work for you or not, and or to be tolerated by you or not. So this is an example of, because I didn't want to kind of potentially breach anyone's confidentiality, this is off the net, but actually I'm going to tell you the story of someone whose profile was almost identical to this, okay? So it was a woman, so I got interested in this based on my GP mates doing it, and this is a woman who'd had severe treatment-resistant depression which had devastated her life, okay? And this is what her genotyping showed, that she had some polymorphisms of her catecholomethyltransferase gene. I'll show you a bit, for those of you who are not clear what that is. For her folate MTHF, so that's creating methyl tetrahydrofolate is one part of the folate cycle. And then these polymorphisms which were risk factors around two inflammatory risk things, the NOS system and the superoxide dismutase system, okay? Forget about the kind of technical jargon in there. And this is just to show the implications of that. So this is the combination of, it's a simple bit of biochemistry, but it has profound impact on our health, including mental health. So there's the folate cycle and the 1-carbon cycle, and within that, catecholomethyltransferase is key in the methylation processes that are involved in catecholamine production, so some of the main brain neurotransmitters. So you can see that if you get a bit of a roadblock in that system, it's going to impact on brain health. And equally, we know folate is profoundly involved in mental health. And so if you get roadblocks around the folate cycle, that will muck things up as well. And then these are like two cogs. So if you get if one clog jams, what's going to happen? The other cog's going to jam as well, isn't it? So, so she had some stuff that was very specifically relating to this key bit of biochemistry related to brain health. This is just to kind of show you that there are physical and psychological and neurological implications of all that getting jammed up. And if you look at the neurophysiology of depression, it includes things like impaired 1-carbon cycle with methyl tetrahydrofolate and SAMe, which is the methyl donor. So basically, if we come back to this, what she started to do, based on a personalised prescription, was to take SAMe, which we've known for years as an effective antidepressant, it's a supplement, to take the methyl tetrahydrofolate form of folate, and also to take omega-3 and N-acetylcysteine as general anti-inflammatory treatments. And over 3 months, she became the best that she'd been for decades, okay? So it's just one little example of how another potential transformational change is ahead of us in ways that are going to enable us helping people. So look, I mean, just to finish, I mean, I personally believe that this whole initiative, the National Mental Health Quality Improvement Program, is the thing that is key to us transforming ourselves. It is how we can change in ways that take people with us if we do it well. So it's empowering clinicians to actually get on, work with consumers and family and figure out how to do things better. And you guys as the teams are the thought leadership. Yeah, and so I just wanted to kind of a little bit focus on what thought leadership is, because I kind of found it fascinating to read this, that it's about others' assessment of you. So, but it's about provoking meaningful change, being curious, having a degree of courage, because change can be scary, and sometimes testing changes that make people concerned about risk does take courage. The key thing, as at least a couple of people have said today, is the thing about starting small, one patient tomorrow, and trying a change idea. Having an environment in which to think. So I think that, that's really challenging when we're day to day constantly facing the reality that there's more demand than we have capacity to meet. But I think that partly, to me, what that speaks to is our organisational environment, so the kind of culture we work in firstly. But secondly, do we have leaders that encourage us to think, to kind of support us in doing things differently and in trying new ways of being? So those are the kind of things that I think are really important for us all to try and find ways of doing more. And again, the kind of ways to lead within the space, which, and certainly in my work and the projects or the campaigns I was involved in South Auckland, these factors came through when we looked at what had actually separated out groups that had succeeded from those that haven't. And it was very much around putting people first. So both staff being empowered, but also actually co-design with people who are using services. Having a common purpose, having the capabilities to succeed. So this whole investment, and I mean, in a way it's a bummer that it's such a crowded room, but to me it's actually a really good problem. The fact that everyone is really engaged in wanting to learn the skills around how to drive this process. Having a culture of continuous learning, of being encouraged to kind of carry on learning and improving. Because at the end of the day, this is what it's about, isn't it?